I normally have fun enjoying meeting everyone in the group. But let me thank the organizers, Dr. Soki, Dr. Twahir, Dr. Sokwala, all of my friends that certainly I have missed this year meeting them. The task given to me this year is the anatomy of dialysis vascular access. And with that subject, I have no disclosures, no conflicts of interest. Yes, the only conflict of interest is I'm missing Nairobi, I'm missing Kenya, I'm missing an opportunity to visit and have a safari this year. The learning objectives for this presentation will be learning the fundamentals of vascular anatomy of the upper extremity, learn the fundamentals of central vein, and learn common sites for AV access creation. So to begin with, let's understand and go back to our medical school days, learning about the vascular system, the arteries and the veins of the upper extremity. So as you can see here, the central arteries, the subclavian artery comes out of the aortic arch and then forms the axillary artery that runs down into the arm as the brachial artery, and the brachial artery follows the medial aspect of the arm and bifurcates into a radial artery and an ulnar artery. These are some of the blood vessels, some of the arterial vessels that supply the AV fistula or an AV graft that is used for providing dialysis therapy. And then the radial and the ulnar artery in the arm, in the hand, they form a palmar arch. So there's a nice dual circulation to the hand, and that's why even if we use up one of the arteries, the palmar arch, if it is patent, prevents any distal ischemia. On the venous side, if we are looking at the veins that start from the arms, we have vessels that run parallel to the artery. So you have the cephalic vein that runs on the lateral aspect of the forearm, and the basilic vein that runs on the medial aspect of the forearm. The basilic vein joins with the median cubital vein and it's connected to the cephalic vein. Then it continues up more into the deeper section of the upper arm. It runs between the two heads of the biceps, enters into the fascia to become the axillary vein, whereas the cephalic vein on the outside, it becomes the cephalic vein on the upper arm that runs through the deltopectoral groove. And the importance of understanding this anatomy is these are the sites where we normally see the stenotic lesions and the pathology that leads to access dysfunction. So again, the cephalic arm on the lateral side of the arm, upper arm, runs through the clavipectoral or the deltopectoral fascia. That's the cephalic arch when we talk about cephalic arch on angiogram, and the median basilic vein runs deeper between the two heads of the biceps, and the two veins together then form the axillary vein, which continues as the subclavian vein. So the peripheral veins and the central veins are the demarcation point is when the peripheral veins enter into the rib cage. So roughly about 2/3 of the subclavian vein is intrathoracic, 1/3 of the subclavian vein is outside the rib. And the two subclavian veins, so the subclavian vein on the right side and the subclavian vein on the left side, are then joined by the internal jugular vein that drains pretty close to the base of the neck. And beyond that point where the subclavian and the internal jugular veins meet, it forms the brachiocephalic vein or the innominate vein, and the two innominate veins then meet to form the superior vena cava that opens into the right atrium. So understanding this is important because when we try to put in central catheters, we don't generally try to put into the internal jugular vein. We never place catheters in the subclavian vein as far as possible, unless it is a absolute last option, to preserve this central thoracic veins, which ultimately becomes the highway to the blood flow whenever a distal AV fistula is created in the upper extremity. So if the preference of placing central venous catheters for dialysis, generally it's the right-sided internal jugular vein is the first preferred site, followed by the left internal jugular vein, and then we move on to the femorals rather than to the subclavian veins. I was just mentioning about this. So when we talk about the central venous catheter placement, without the ultrasound, which is not considered to be the standard of care, but at least it provides us with the landmarks that are required to use the ultrasound to identify the internal jugular vein in the triangle, the two heads of the sternocleidomastoid, and the base is formed by the clavicle. And we generally try to go with a tunnel catheter as low down in the triangle, close to the clavicle as much as possible with the ultrasound guidance. In non-tunnel catheters, it would be okay to be closer to the apex of the triangle and allowing us to leave the space below the puncture point for the non-tunnel catheters to place a tunnel catheter if and when required. On the femoral side, the popliteal vein in the lower extremity extends up into the thigh as the femoral vein. The femoral vein is easily accessible in the femoral triangle that is formed by the sartorius, the inguinal ligament, and the adductor longus. And the femoral vein is medial to the femoral artery, which is easily palpable and visualized with ultrasound. Moving on to some of the applied use of this anatomical variations that are seen in these patients, the ultrasound easily helps in identifying the artery, the carotid artery and the jugular vein in the neck. The carotid artery is a fairly circular structure with reasonably thick wall and difficult to compress, whereas the internal jugular vein is can be of different luminal shape. It is thin walled. It may have transmitted pulsations from the carotid artery, but it easily collapses with minimal compression. And if you look here, the most common association between the jugular vein and the carotid artery is superolateral, but oftentimes we do see carotids that's right above the jugular vein that's right above the carotid, or even rarely right below or medial to the carotid. So hence, a blind procedure certainly can lead to more inadvertent puncture of the carotid artery or hematoma formation. With ultrasound, you can select, we can identify and select the path to enter into the vein alone. The same is true with femoral veins. So here you can see the femoral vein and the femoral artery. And again, the artery and the vein is medial to the artery. Most of the times, it's fairly far away from the artery. So it's, if you align your ultrasound probe, one can easily avoid the puncture of the femoral vein. Rarely the femoral vein is behind the femoral artery, and one may need a lateral approach to enter the femoral vein. So putting it all together, we have the upper extremity blood vessels. We have the subclavian artery that runs down the arm on the medial aspect of the upper arm as the brachial artery, which then around the level of the elbow bifurcates into the radial artery, which is on the lateral aspect, and the ulnar artery, which is on the medial aspect. And the two arteries then form a palmar arch that supplies the hand. And on the venous side, the cephalic vein runs on the lateral aspect of the arm, both the forearm and the upper arm, enters through the clavipectoral or the deltopectoral fascia, which is very commonly referred to as the cephalic arch. The basilic vein on the medial aspect of the arm communicates with the cephalic arm with the median cubital vein, runs up between the two heads of the biceps, joins to form the axillary vein where the cephalic vein enters, and then in the rib cage, the axillary vein becomes the subclavian, joined in by the internal jugular vein at the neck of the base of the neck, and continues further down as innominate vein, the two innominates vein join to form the superior vena cava, which empties into the right atrium. And why is this important? Because the most simplistic way of assessing an AV fistula or an AV fistula is with a physical examination and understanding the inflow. The inflow is not just at the anastomosis, the inflow starts at the heart and the entire arterial tree. If it's a radiocephalic fistula, the heart, the entire arterial tree, and the anastomosis becomes the inflow. And the inflow then, anastomosis opens into the body of the fistula, which is where the cannulation zone is, and then empties into the proximal veins down further into the central veins. So essentially, it's a circuit that starts at the heart, runs through the arterial tree, returns through the venous tree, through the central veins back to the heart. So understanding this anatomy helps one identify dysfunctional segments that can then be treated appropriately, either endovascularly or with surgical interventions. And here are some of the common sites. So any places in the upper extremity where the artery and vein are in close proximity, the commonest site is the radiocephalic vein and the radiocephalic fistula between the cephalic vein and the radial artery. Even further distal, right behind the thumb, the cephalic vein is close to the radial artery, and a snuff box AV fistula can be created in a select group of patients. The next possible access site is the brachiocephalic fistula, which is the cephalic vein in the upper arm and the brachial artery. And the proximal forearm fistulas are now being used and created with the help of endovascular devices. The transposed basilic vein is more involved. Generally, it's at one stage or a two stage, depending on the surgeon's preference, but it requires superficializing the deep basilic vein into a tunnel in the upper arm, so it can be easily accessed during dialysis. And the cephalic vein, the basilic vein is then anastomosed to the brachial artery. So clearly where there is a change in the plane from the deeper plane to superficial plane, that's the swing site where stenosis is fairly common. And if fistula access is not possible, then graft is the next best option, where grafts can be placed in the forearm in the form of a loop, or in the upper arm in the form of a straight segment or a loop segment, in using any of the patent blood vessels. Either it's a basilic vein or an axillary vein, or even the brachial vein sometimes. So as applying this knowledge of anatomy, vascular anatomy, the common vascular accesses that we place and we often use, and we have been using it for the last 50 years, is arteriovenous fistula, which is the most common, starting distally and progressing proximally as the fistula fails, an arteriovenous graft between any two sites, the tunneled cuffed central venous catheters or non-tunneled central venous catheters, which are generally placed in the internal jugular vein, right preferred to left, and then if both right or left are not possible, then placing them in the femoral vein. And in rare situations where the patient has been on dialysis for a prolonged period of time, has lost out most of the common sites, then non-conventional sites such as translumbar or transhepatic catheters are often placed. This also leads to understanding that there are several newer devices that are now available that can be used in patients with complex vascular anatomy from multiple failed accesses in the past. So a HERO device, or hemodialysis reliable outflow device, which is a hybrid catheter and an AV graft. the catheter portion is the outflow portion placed in one of the central veins, and distally it's hooked up to a AV graft that is then used for cannulation during dialysis. There are bioengineered vessels that are now available at the HUMA site. The early studies are very promising, and again, these are vessels used, these are artificially created human cellular based vessels used to create an artificial AV axis. And as mentioned earlier, creating an endo-AV fistula, so between the wrist and the upper arm fistula, using the deeper vascular structure in the forearm, one can create an endovascular fistula using some of the perforating veins and the adjacent radial or ulnar artery. And with that, I end my presentation. I'm more than happy to take any questions. Feel free to contact me. I'm sure the organizers should be able to provide you with my email address, and I'm more than happy to give any feedback. I will try to join the question and answer session live, but it will be about 3 o'clock in the morning for me. So if I'm unable to join, please excuse me. And once again, I am missing out on meeting everyone in person, but I wish you all the best. Please stay safe, and hope we can meet again next year. Thank you very much for inviting me.